Hello, everyone. It's my pleasure and my honor to welcome you tonight to one of our weekly online series. On behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome the speakers, moderators, and attendees to the creative and prestigious continuous opportunity to deliver not only an up-to-date curriculum in the field of anesthesiology, critical care, medicine, and pain, but also to gather unique speakers and moderators from all over the group. This opportunity is and will remain a great and successful experience in the current and the future virtual learning. Let me introduce Dr. Gloria Rodriguez-Vega tonight. She's better known as Gloria, and she's a Puerto Rican-born internal medicine critical care neurocritical care specialist, a magna cum laude graduate from the Cornell University, and later cum laude from the Universidad Central del Caribe School of Medicine. She finished her internal medicine residency at the VA Caribbean Healthcare System, and afterwards completed her critical care medicine fellowship at TMH Brown University. She returned to her beloved PR to direct the VAC Surgical ICU for 6 years, after 4 years directing the UDH Neurosurgical ICU. She moved in 2010 to direct the Neurosurgical ICU at Jaime San Pablo Caguas, a private hospital conglomerate in the island. At present, she is also a chief of the Department of Critical Care Medicine. She's assistant professor at the University of Puerto Rico School of Medicine, Ponce School of Medicine, and Universidad Central del Caribe School of Medicine. She is currently involved in the numerous international and international societies. She is a council member of the Society of Critical Care Medicine, and she's president of Consejo Centroamericano y del Caribe de Terapia Intensiva, a former council member of the Federación Panamericano Ibérica on Medicina Crítica y Terapia Intensiva, and past president of the Puerto Rico Society of Critical Care Medicine. She has been a speaker at the local, national, and international level, and has publications in peer-reviewed journals, authored books, chapters, and is a co-editor of the books Critical Care Administration, labeled A Comprehensive Clinical Guide and COVID-19 Pandemic Lessons from the Front Line. She lives happily with her beautiful daughter, 2 opinionated dogs, and an understanding husband. Dr. Rodriguez, it's all yours now.
We are advancing to our last, but not least, panelist, Dr. Marcio Borges. He sent me a very short bio when I asked him, but he is greater than that short biography that he sent me. Dr. Borges is really well known and a professor in infectious diseases at the Baleárico universities. He's director of Sepsis Committee of the Pan American Federation of Intensive Care Medicine. He's the national director of Sepsis Code, main investigator of sepsis. When you think of Marcio, you think of sepsis and pushing the boundaries and trying to impact that number in mortality. And I have deep admiration for you. And it's an honor for me to be presenting you. He is the founder and president of the Sepsis Code Foundation, and how he has translated the urgency of managing sepsis and trying to get an impact in that sepsis mortality. He will be talking to us about personalized management of sepsis. Is it possible? So Marcio, welcome.
Thank you so much for a nice presentation, Gloria. First of all, I want to thank so much the mega organization, especially Dr. Sadi Madi for this nice invitation for me. And I don't have a easy, because I have a great problem in my presentation, because before I have a 2 excellent presentation about the sepsis, but it's not easy, but I try. I have not conflict of interest for this conference. Sorry, but I will invite you to the second edition of Technosepsis. We will receive almost 50 international experts from 20 countries, and we talk, discuss, dynamic discuss about different topics such as microbiome, artificial intelligence, and use of new therapies in sepsis management. So, and I have a special thanks for my team. I am fortunate because I day by day work in research and clinical assistance with a very important multidisciplinary group. This group is formed by different specialists, nurses, pharmacologists, biochemists, physics, mathematicians, computer scientists. Is fortunate that I have an opportunity to work day by day with them. So I will start with an advertised sentence. If you are looking for different results, don't always do the same thing. It's think it's a great problem in sepsis. No, you make same things in different or heterogeneous kinds of patients. So the question is personality management of sepsis. Is it possible? Yes, but I have 3 different questions: how, when, and why. These are other very important questions to answer. So, why have most diagnosed and therapeutic studies failing sepsis in the last 30 years ago? I have many possibilities to answer the question, but the most important is that we are making errors of perception and analysis and assess. The kind of studies to explain, to use of causal effect of sepsis, of diagnosis, of different types of therapies is not so good. So, and the other problem is we want to simplify an extremely complex clinical syndrome like a sepsis. Sepsis is a syndrome, it's not only a disease, no? So, in our agenda, we talk the 3 different points: the problems of personalized management of sepsis, second, the clinical experience, and the focus in big data, artificial intelligence learning, technologies apply in the detection of sepsis, and finally, we will talk about our experience in artificial intelligence and nanotechnology. So the first, sepsis is a very complex syndrome associated with different causal agents, pathogens, virus, and kinds of bacteria, and have a different human host. It's not the same, the patients is a different, the same infection by Pseudomonas aeruginosa have a different patterns, pathways, source of action, and genetic predisposition. So as you can see, we have more than 300 mediators, biomarkers associated direct of sepsis. So it's not easy to understand, or in the case of the definition of sepsis, using score, using only 6 variables to explain the complex syndrome. For example, don't use cause of barrier function, don't use immunoparalysis as an organ dysfunction tool, no? So, in this moment, you have a great opportunity because you have a new revolution in the medicine. This is a technology convergence that's based in 4 scientist topics: nanotechnology with atoms, the biotechnology technology with using cells, sensors, cytokines, the cognitive technology using neuronal networks to explain, for example, genotypes or phenotypes, patterns, and finally, the use of informatic technology using the bytes that use of massive data and they interpret these cases. No? So, for example, nanotechnology and sepsis in the last 2 years before the pandemic, they increase the double the number of articles based in this topic, no? And the real role of genotypes to identify biomarkers is not only the risk assessment and the first moment of sepsis. The genomic had a very important influence in the predisposition, the response of different treatments. For example, the complex relationship between the pathogen, the genotype of the pathogen, the multi-resistance, and the phenotype response of the host. So as you can see, the transcriptome expression profiles showing up or down regulation genes is a very important to identify is a inflammatory or immunoregulatory immunoparalysis. So it's a very different. This difference is between in different phase of sepsis. So it's possible in the start of sepsis, the first hours of sepsis have the upregulation, and after is a downregulation. For example, in COVID-19, you have this experience. No? So it's important to know the risk factors, for example, the age, the comorbidities, the causative organisms, the virus, fungus, bacteria, and the treatment. It's not chronic treatment. The treatment of the use of antibiotics have an influence of in the biomarkers. For example, you do know that you use a right doses and correct, adequate antibiotic decrease very fast the PCT levels, no? So the biomarkers based in metabolism, cellular function, phenotype, and finally the consequences, the organ function, dysfunction, or of course the death. So the biomarkers based in different patterns, the cellular function, protein signatures, metabolites. And finally, the endotypes. It is very important to identify this endotype, these phenotypes, because change so much. It depends in the phase of sepsis, of course. So, finally, these endotypes is going to promote a personalized treatment, personalized diagnosis. And of course, the objective, the personalized, the precision therapy is improve the sepsis survival. No? As you can see, in the last years, several therapies are being investigated in sepsis. No? So, for example, cytosorb have a good findings in observational small studies, but in randomized trials is not good. The findings is not good, so results. And on the other hand, for example, the promising therapy with interleukin-7 in patients that is possible to suppress immunoexpression of these patients. So we have the nice possibilities in the future, but it's very important. This is not a single treatment for all types of sepsis. This is impossible, no? So the future is they combine different therapies. For example, in COVID-19, we combine prevention, combine antivirus, combine immunotherapy, combine immunotherapy associated with that. So the four topics very important in genomic, transcriptomic, proteinomics, and metabolomics, and the relationship between them have a possibility that a pharmacotherapy, a guided pharmacotherapy using pharmacogenomics and pharmacometabolomics. And this is important to mechanize of drug action using the PK, PD, pharmacocinetic, pharmacodynamic parameters for design the better drug if that have a better response according to different phenotypes of the patient. So the aim is design personalized treatments for each special patient. So it's not possible one treatment for all patients. And the first moments of the COVID-19 pandemic, we published this opinion study, opinion article based in the personalized therapies in first 2020, and according the phase of COVID-19 infection based in the patient's mild, severe or critical ill situation. So it's possible to design personalized therapies in different situations. So we must be use intrinsic, extrinsic factors. This is combining data source is difference in genomics, transcriptomics, proteomics, and metabolomics, and they use the bioinformatics, the big data, artificial intelligence, and machine learning techniques to develop the better personalized medicine in diagnosis and treatment and design, for example, identify phenotypes. So the clinical experience that I focus in artificial intelligence, machine learning, and we have three possibilities to detect sepsis. No, the first, the vast majority of times is a human capacity. No, the second is using automated electronic systems based in classical static scores such as SOFA, QuickSOFA, SRIS. And finally, the using of machine learning, artificial intelligence techniques, both human and automatic system using a linear thinking. Meanwhile, the artificial intelligence uses the exponential thinking. This is a difference not only restricted to data speed, but or the capacity of memory, but also how they formulate the complex algorithms. Do you remember? Sepsis is a complex system, need a complex answer of the question. So there's different studies based in artificial intelligence is 5 topics in prediction, patient that possible develop sepsis, detection, that this patient had a sepsis, diagnosis, prognosis, and treatment. And of course, to identify phenotypes of different phenotypes of patients. This is a great advantage of use of machine learning studies. So, machine learning models for sepsis, I like so much. I think it's the best, the better study by review and meta-analysis until the moment by my friend Lucas Florey. In this meta-analysis, they identify that almost 30% of studies in artificial intelligence use the same group, the mimic group in the United States. The majority of studies is a retrospective by personal data for one hospital and have a very few prospective studies. No, this is a limitation to expand the use of machine learning. Finally, in this study, they identify more than 3 million patients. No, that most of the studies use an sepsis tool and restricting ICU sitting only one, and very few studies include all patients in all parts of the hospital. And as you can see, they identify 43 different variables associated of sepsis, vital signs, demographic, laboratory, or observational studies. For example, type of one type, the level of potassium, calcium, bicarbonate, kind of unit. So these variables, the most of these variables never be included in any score of sepsis. So it's not included in SOFA, in sepsis 3, or NEWS or other scores. And this, in the meta-analysis, the area under curve for sepsis detection is excellent. It was excellent in this meta-analysis between 0.75 until 0.95. This majority of these studies have more than 0.85. This is a better results for detection sepsis of other classical studies in published in literature. And if you compare the machine learning detection with a classical scores of QuickSOFA Mills, as you can see in this study in the United States, the machine learning had a better error curve specificity, predictive, positive value, and accuracy. So using these techniques, improve the capacity to detect or prediction sepsis. So another advantage is use these techniques for identify different phenotypes of patients better than conventional models. This is, I think, the most important studies about this topic is a study by Seymour. They used 6 different databases for develop those different phenotypes, and as you can see, the authors identified 34 variables. Some of these variables are similar of the Lucas Florin study. No? So these include different variables that never include in our scores. No? So finally, they identified 4 different phenotypes, 4 different clusters. No, and the important is different phenotypes have a different consequence, different outcomes. As you can see, the alpha phenotype is the most frequent phenotype, 33% of cases in ICU. It's a very important remark this. And the mortality in hospital mortality is only 2%. Compared if a delta that have only 30% of cases in ICU, but had a higher mortality, higher significant mortality, than 22%. So it's important to identify phenotypes, to identify, for example, if make a different management, treatment, diagnosis, early diagnosis, or early treatment in these patients. And this is a very interesting study that used the genomic patterns for identifying the prospective study for identifying 2 different phenotypes. It is identified the sepsis response signatures, side 1 and 2, and the second one related patients with immunosuppressed phenotype that use endotoxin tolerance, T-cell exhaustion, and downregulation of classifiers. 2 is this predictive model was based in 7 different genes for classification. It is important, similar to other studies in discovery cohort and the validation cohort, the group 1, the immunosuppressed pattern, had a significantly more mortality in 40 days, 20 days, 6 months than the second group. So, in phenotypes in COVID-19, this is a very interesting study in Spain that I get the opportunity to participate to. In ICU in Spain, more than 2,000 patients to develop different phenotypes based in a combination of demographic, inflammatory, and organ dysfunction variables. No? We identified 3 different phenotypes. The phenotype C is a more frequent, is a COVID-19 severe. The patient was old, have a higher Apache 2, SOFA 2, have more inflammatory variables. It have a more myocardial dysfunction and shock than the other 2 groups. So, and the clinical impact about this. This is, I think, the best study about this topic is that evaluated mortality, length of stay, and readmission in the prospective multicenter study in the United States. They use only 5 variables to develop this machine learning algorithm. Is a systolic and diastolic blood pressure, heart and respiratory rate, temperature, oxygen, and age. So it's important the study include community hospitals to large academic medical centers. No, in many patients in this study. And the most important, the use in the prospective real life study that use of machine learning models for early identification. The author identified lower mortality, 39%, lower length of stay, 32%, and 32% lower readmission than previous period. So the impact is incredible in the multicenter in the study that validate this algorithm. So For the end of my presentation, I will talk about our experience in two special points: the artificial intelligence machine learning techniques for early sepsis detection and prediction, and finally in nanotechnology for diagnosis. No, so I live in Baleárico Island. Had 5 islands. In Palma de Mallorca is a capital. Has about 1.5 million inhabitants, but in this period we have many tourists. So my hospital is a university hospital. This is a characteristics of that, and we have a special things. Our hospital implemented the first sepsis code, since 2006 in Spain. We developed the first multidisciplinary sepsis unit since 2010, and we developed one automatic electronic sepsis alert since 2011 in real time. But we have a problem because it's a many cases of false positive, almost 65% of false positives. So this warning is restricted to members of multidisciplinary sepsis only, because the possibility to fatigue of other colleagues in emergency department wards is a real life. So in science 2018, we developed artificial machine learning sepsis project that we call BISEPRO. We have 2 different research institutes in artificial intelligence, Instituto de Inteligência de Conhecimento, IDISBA, and the objective is create a new forms to develop different algorithms for sepsis management. So our main objective was provide intelligent tutorials for supporting real-life clinicians within the concept of personalized and precision medicine to the form of group the multidisciplinary teams with clinicians, with mathematicians, computer scientists, and we develop in 3 different phases. The first phase is a retrospective. This first phase was finished, that you develop different predictive models of sepsis with these techniques compared with classical scores, and the other 2 phases is a prospective real-time that include all patients, is a predictive for detection and prescriptive to decision-making tools. So this first phase is a finish. So in the retrospective phase, main objective was to minimize the false positives, increase the true positive predictive models. This period during 5 years. They set in our hospital in all areas, emergency department, wards, the ICU, and the use of sepsis 2 criteria, severe sepsis, septic shock. You remember that most of the studies using these criteria for sepsis definition, but the important in different of other studies, we have a prospective, a supervised validation by clinicians of all cases, not use of codification by discharge, clinical charge. So we use a demograph, vital signs, pharmaco variables, microbiology findings, laboratory data, and they use unstructural data based in triage, based in 3 tests from nurses and physicians. These are different of others studies that only use structured data by the algorithm. So these are phases of retrospective project, the use of data, descriptive analysis, pre-processing data, selection of variables, prediction, and finally, the selection of better model for sepsis detection. As you can see in these 5 years, 2014 until 2018, we identified more than 9,000 patients that had previously been validated in real time, and in total, more than 200 patients, including our assets. So, using only demographic, clinical, analytic variables associated of sepsis, severe sepsis or sepsis stroke, at least one organ dysfunction, we identified 65 variables, significantly higher if use the classical scores as area, CIS, and SOFA score. No? And it's very interesting because according the unit, emergency department, internal medicine, infection disease ward, surgical ward, the different variables associate or not associate sepsis. So this is a general form to identify phenotypes according the unit. Surgical patients are different of patients in internal medicine. So this is important to identify the possibility of different phenotypes. And we have generated several predictive models by setting 4 different groups. The classical models, using, for example, sepsis 2 or sepsis 3, combination of classical scores, sepsis 2 plus quick SOFA, sepsis 3 plus quick SOFA, sepsis 3 plus SRS. The third group is using only much learning, that this is not had any influence of physicians, clinicians, and finally the combination of much learning and classical models. For example, much learning plus sepsis 2 or much learning sepsis 2 or quick SOFA. As you can see, the classical scores, for example, sepsis 2, had the area and curve very good too, 0.88. Specificity decreased very much. But in blue, as you can see, the 3 different much learning models have an excellent area and curve sensitivity specificity. It's not the difference between the 3 models, 3 blue models. No, as you can see, is a different. Is a significant difference between the much learnings and classical scores. Is a better of much learning scores. So the second phase is a predictive in prospective real-time outpatients. This is a first a predictive is a pilot phase in our hospital during different periods. In 2019 until July 2020, this alerts us is each possible sepsis, severe sepsis or septic shock, and the members of multidisciplinary sepsis receive and validate this case of sepsis. So this is an early detection, prediction of possible sepsis of sepsis using the algorithm that we training in the retrospective study that develop predictive models. We develop role system, much learning system, different types of alerts, as you can see in this chart. And you can see this is a findings that you received a very few days ago. The use of BSEPRO had a BSEPRO is a much learning plus sepsis 2 had an area and curve in prospective validation study, the 0.95, the similar of the retrospective. In the use of classical, the classical scores, they decrease the area and curve, the 0.85. But the most important is as exactitude of the value is a significantly lower in the classical score than much learning score. So in the next November, we started the validation, the double validation for clinicians in real time and validated by multidisciplinary sepsis unit in 4 different public hospitals in Spain. And finally, in the next 2023, we developed the decision-making tools by individual diagnosis therapeutic and prescriptive study. And we have different publications in our group in nanotechnology. This is one example. In the last 3 years, almost 20 publications in this nanotechnology and sepsis. For example, rapid detection of Pseudomonas aeruginosa in respiratory samples, in 15 minutes using the mobile telephone to identify, to quantify, and the possibility identify multi-resistance patterns of sepsis, or the use of the nanosensors for identify neutrophil hypergranulation. And the normal patients have higher hypergranulation in comparison of patients with the sepsis that have decreased the capacity to the granulation. As you can see in this table, the septic patients have a lower nanotechnology patterns for sepsis identification. So finally, I think it's a personalized sepsis have a new paradigm shift. No, they have a very, very good advantage: high sensitivity, specificity, decrease the mortality, use all data, use all different phenotypes of patients, have different models. It's a possible use of unsupervised or supervised, and we design and personalize in the precision medicine. But we have a pitfalls, no, in relationship is that most of the studies were retrospective. The safety of data is very important. This study is not used real time, is not prospective, and it's very important how to model learning. No? So the majority of the studies based in code, discharge code, this is almost 50% of bad sepsis identification. So the next wave of artificial intelligence aspires to create machines that will function more as colleagues than as tools. I think this is possible. It's not expensive. The use of this technology is not so expensive. So I remember, don't forget Sepsis Codex, and many thanks for your pay attention.
Thank you, Marcio, and for this fascinating lecture. Definitely a paradigm shift. And I want to start with that same topic and how we have been pushing boundaries throughout this webinar. And in this requirement of paradigm shift and the way that personalized medicine for sepsis treatment, what challenges and barriers, and you mentioned some of them at the end, do you anticipate that we are going to be facing?
A very good question. A very, very, very good. Sorry?
No, go ahead.
Okay, thank you. It's a very, very good question because it's not so easy to answer. The use of conventional classical scores, as Javier explained it before, it's impossible to early identify the patients. The other possibility, the using of machine learning techniques, is predict sepsis before they started, 20 or 24 hours before. For example, in our experience, until 48 hours before that you have a normal concept of sepsis. Of course, the use of genomic, transcriptomic, phenotypes patterns is a crucial point to identify, to make a personalized and guided therapy in sepsis. It's very difficult that the normal management of sepsis have a good result in sepsis because this mathematical complex system, no? So it's impossible to join pneumococcus infection, pneumonia with abdominal infection, peritonitis by fungus combined with bacteria. So, and of course, depends of the population, the genotype. For example, in our experience, the use of our algorithm for detection of sepsis changed in one or another hospital. For example, we test in a small hospital, in the big hospital, the same algorithm. In the small hospital, have a little difference, but the bigger hospital have a more difference. The reason, the patients we have not neurovascular, neurosurgery, cardiovascular surgery. We have a few transplantation patients. So the pattern, the phenotype, the kind of patients change so much. So the future is not the future for the next 10 hours. The future in the next 1-2 years is introduced to combine the different patterns, use machine learning. It's impossible on the use because it's too early to anticipate and diagnose the treatment. Is very, very important. Introduce change in our mind is a danger for physicians. The physicians in the next 10, 15 years old is a change the form to work.
Thank you. And I want to remind the audience, you can put your questions in the chat. I will continue the conversation while you put your questions. I asked Dr. Hidalgo in his question, in his first lecture, why was it so hard to identify this cascade of events? And I think you've provided some answers. What do you see as the role of you've mentioned the role of biomarkers, the role of nanotechnology, the role of AI and machine learning. But we have areas around the world that have limited resources. Is that achievable also in limited resources areas to get to this point of using personalized medicine?
I will answer that. I think so. The pandemic it opened many doors, and one of the doors that open is the collaboration. I believe the resource limited countries it will benefit a lot from this collaboration that we can establish, and it's been established already in many of our countries. And one of the things that we have as a country is the collaboration with Baylor College of Medicine. Some of the collaboration we will present it in Technosepsis, but we have the opportunity to Belize to have nanotechnology in our laboratory. And even so, I always ask the people if you are familiar with the Minions, the movie, no? Mm-hmm. And then one of the in the past when we talk about the possibility of do nanotechnology and especially to identify the variants for COVID, we imagine those big cubicles, but now with the collaboration of Baylor, we introduce that we call it the Minions, with nanotechnology to identify the variants that is like on a small cell phone, and you are able to identify your variants. I mean that it's doable, but of course it requires establish the links, networks, and collaboration. But not only that, to be able to cultivate that, and I believe that is very critical that we can continue that and to establish those links.
Also, Jorge, I'm sorry, Marcio.
Yes. No, it's only one question. It is it's very important to remark this the big data techniques and nanotechnology techniques is not expensive. It's lower expensive if compare with microbiology tests, molecular tests. So it is very important because in countries we have a low economic conditions, is can to introduce these techniques.
Yeah, and also what we've been talking, that sepsis is not only a medical problem, it's a healthcare and public health issue. So to get to this, you need to involve the administrators, the government, and those type of relationships around the world to be able to save lives with sepsis. One last question for you, Marcio, and we also have questions from the audience, and then I'll bring the whole panel for closing remarks. Where do you foresee the use of quantum dots in the future? Is that something that's very close for point of care treatment of sepsis? Is that something that we're close with the data that you have and your research, or is that something that, it's something to see in the future?
I think I see in the future, but this is a real possibility. Of course, combined with others, techniques, other technologies, But I think it's a possibility. It's not so close a possibility in the far away, but it's a good possibility.
Thank you. We have 2 questions from the audience. For discontinuing antibiotics, should we use Procalcitonin or CRP? I don't know if Marcio or Javier can answer this question.
Well, yeah, I can give you my perspective on this. CRP is probably not a good surrogate to determine the presence of infection. It is really too open to any other inflammatory issues, and so it's probably not. Procalcitonin, if it was elevated and following the trend, might be helpful. Again, it all depends on whether it was already elevated, and you can follow that. So a single value will not be adequate. A follow-up on that, but that also adds, so let me be clear, that also adds a cost to the treatment, and I am not completely sure that gives you any clinical benefit on doing that. So very, very bogus help from the use of Procalcitonin in any way. If you have it, definitely yes. Asking for it, probably not.
We use a PCT, Procalcitonin, joined with a clinical evolution, the follow-up of these patients. We use only biomarkers. It's not correct. For example, the patients that COVID-19 that use tocilizumab and after develop a bacterial infection, is not increased PCT, increase RCP. So depends of kind of patients, of phenotype of patient again.
Thank you. And we have another question from the audience regarding broad spectrum antibiotics, which is best?
Which is best? The best one is the one that really cures the patient. So let's say that way. The second best is the one that you have available. So that might be my point. Now, I think, on the serious matter, I think it's really depending on many factors, but some of them jokingly, I say that, depends on your particular environment. So if you suspecting, so number one, it depends on what you have around. Number two is what you suspect in your particular patient. So I might tell you, if it's a pneumonia coming from the community, and you have a high prevalence of resistant strep pneumonia, then obviously your antibiotic choice will be totally different than if the expectation is non-resistance. However, if you have someone who is diabetic, then that might be different than if it's not diabetic. So it's difficult to assess. Typically, we have to cover in patients with sepsis. It depends again. There are particular guidelines. There are guidelines that can be specifically look at the Surviving Sepsis campaign, but there's also the ASIM has guidelines on the use of antibiotics, and the Institute of Infectious Disease of America has other management guidelines. But again, the most important is to look into what you have in your area, what you have in your region, and what the particular elements affecting your patient are. And that's really the best determination of, and always try to cover every possible corner initially, and then de-escalate after you confirm or rule out the presence of or the absence of an infection.
Thank you, Javier. And now for the panel and our closing remarks. And I want to thank the audience because we've gone over a 2-hour mark, and we're sort of like 24 minutes over, and we'll take a couple more, but I want to thank you all. To the audience, we have over 6,000 people in our YouTube channel listening to us, and over 2,000 in the Mega website. So thank you for your support. There's also a survey that we ask you to fill. It will help us, and it will help Mega in developing content for future lectures. So please do that. Two things that I'm going to ask each one of you, and following the topic of pushing boundaries of knowledge, what do you foresee as the future of sepsis? Jorge.
Well, as I say, I start with the pushing the boundaries of knowledge, and I think so. What I basically are saying that is basically time to think differently. The way we are seeing sepsis is not working, and we need to give open to new opportunities, new possibilities. Personalized medicine is definitely one of the things among many others, but I think so we need to think this process in a different way.
Javier? Marcio, that's okay.
I think this is a new paradigm in the medicine, in the sepsis, of course, no? The early identify, diagnosis, therapeutic guide based in the patient, based in the one patient, is a similar of oncology therapy, oncology treatment in this moment, no? We know, you must know the genotype, phenotype, characteristics of each patient. So this is a new revolution of medicine, no? The use of new technologies for build the better diagnosis, the personalized diagnosis and treatment with each patient. So Javier talk about the use of antibiotics. The antibiotic is personalized antibiotic, is a different one or another pathogen that's a virulence of Pseudomonas or Haemophilus influenzae. So depends of the close relationship between pathogens and host to develop the better personalized management of sepsis.
From my standpoint, Gloria, it's a summary of what everybody else has said, and I think it's personalizing sepsis is really targeted treatment to every personal individual. I think it's really what we're moving towards, and the question is how to reach that. I think technology is definitely going to help us, and that's what I think is the future for management.
Well, before I hand over to Ahmed, one last question to you, and I want you to answer that in one sentence. So what is the take-home message regarding sepsis and prevention management and this seminar? Jorge.
Sepsis is time.
Marcio?
Technology saves lives.
Javier?
We need education.
Thank you all. Thank you, the audience. And you have been wonderful. And I will be handing over to Ahmed for closing remarks.
Thank you.
Thank you so much, the mega organization. Thank you so much.
Thank you.
On behalf of Dr. Saad Mahdi, I would like to thank every one of the speakers, and special thanks to Dr. Gloria for this excellent moderation role. I've been learned a lot today, and I have to thank all the audience for patience and tolerating us for 2 hours and beyond. And I hope the next session will be an excellent one like this one. So thank you, everyone.
Thank you.
Thank you.
Thank you so much. Goodbye.
Thank you.